Hi, my name is David Bishop. Today I'm going to speak through sedation principles and some scenarios, specifically concentrating on how we would do sedation in a district or a rural hospital setting. Now, I have spoken about how to do anesthesia for an evacuation of the uterus before. You'll find that video on the YouTube channel. That talk concentrated on the procedure and on some of the methods of anesthesia and some of the principles of sedation. But just because a lot of people want to know how to do this particular procedure, if you're looking for a more in-depth talk about that, go and have a look at this one. It's just under half an hour. Right, so some of the principles which are important when doing sedation. The first is that there's this misconception that sedation is easy or easier than anesthesia. And one of the principles that anesthetists certainly work by when in bigger systems is that when we're asked to send someone to go and do sedation in the ward, certainly from my point of view, I look for the most senior free anesthetist. I don't get one of the juniors because I consider it a hard thing to do. It's a difficult thing. You're out of your normal environment. You're often using unfamiliar equipment and unfamiliar drugs, and the procedures may be unfamiliar to you. So anesthetists tend to send senior people to go and do sedation, whereas I've noticed in other disciplines often it's the more junior people doing this. And it's a misconception. It can be easy, but it can also be very, very difficult, and the outcomes are actually worse. If you look at deaths during sedation, they're higher than for general anesthesia. So it's worth taking this subject seriously. You certainly can make it safe, but there's some important principles. Listen out for this sentence. When you say, I'm just going to do it under ketamine, or I'm just going to try and get away with some sedation, those sentences are often applied to sick patients where people are nervous about doing an anesthetic. And you don't want to be doing sedation in order to avoid the GA unless you really know what you're doing. So that sedation may be the best option, but just be careful. Get yourself into a safe environment with a lot of staff and a lot of equipment when you're thinking like that. And then finally, I'm speaking to predominantly a non-anesthetic audience. Do what you know. So the best way to do sedation might be propofol infusions, but if you really know the drugs midazolam and morphine best, perhaps that's the safest in your hands. So don't necessarily go for what is most elegant, go for what is safest and most effective. And use sedation as an opportunity to improve your service, because often when you're doing these things in the ward or in ED, you can use them to improve your environment. So get better monitors, get staff used to doing these procedures, run through checklists. There's a number of things you can do to improve your environment around sedation, and you can improve your skill set, the handling of an airway or just the way you set up for a procedure. There are all sorts of skills, blocks that you can do. Use sedation to improve your environment and your skill sets. And remember that there are guidelines on this. This is the SASA sedation guidelines that apply to 2020, from 2020 to 2025. And they've got very clear outlines of what is acceptable and what isn't, written for anesthetists. So it perhaps is not for the generalist anesthetist, but it's a useful document and certainly one that I'm applying during this talk. So one of the first things that you need to ask when you're about to do sedation, there's 4 basic questions you must ask. How is your patient? Is this a well, healthy patient undergoing a procedure, or are they sick? What procedure am I doing? What anesthetic would be appropriate? And where should I do it? And those 4 questions you're going to ask every single time you do sedation. And just remember, just because the procedure might be fixed, the fact that the patient is sick might mean you should do it somewhere else. It might mean you need a different anesthetic. So those 4 questions don't necessarily always result in the same answer in terms of how you should do it. So I'm not asking when you ask, how is my patient, that you do very extensive things. What I am suggesting you do is that you remember to examine your patient before you start doing the procedure. When we do a list in a regional hospital and we're doing evacuations of uterus, there's always one critically ill patient on that list of 5 or 6 patients. There's always one, and the only way you pick them up is to examine. You need to find out, is this patient acutely unwell? Are they chronically unwell? Do I need to resuscitate first? Beware of the septic patient. And all I'm asking that you do, I'll look at some basic clinical things. What's the heart rate? What's the blood pressure? What's the respiratory rate? And what's the GCS? A low level of consciousness is a very worrying sign. High respiratory rates are very worrying. And then perhaps more subtle, when that heart rate starts to climb and approaches whatever the systolic blood pressure is, especially when the heart rate goes a little bit higher, that's telling you something. It's telling you that patient's perhaps on the edge of hypotension. But very simple clinical indices. If you just make note of those 4 things, you're going to pick up the vast majority of unwell patients. Special investigations, usually for sedation, there's not a whole lot you need. It'll be defined by the procedure. A ward hemoglobin is perhaps the most you need. But just remember to ask the question, do I need to do anything before I do this procedure? And then just a last point, stand back from the patient and say, am I dealing with a special population? Is it a very old patient or very young? Is the patient obese? What's my gut feel about the patient? Am I worried? Am I looking at this patient thinking, this could be difficult? And whenever you get that sense of this patient is one of those special populations, then start thinking, can I do this in a safer environment? Should I move to the emergency department or the theatre? Should I get more staff in? Am I capable and equipped to deal with the complications that might arise? So when you're asking what procedure, and let's just say for instance, the procedure you're going to do is an evacuation of the uterus, that should immediately make you think about a number of things. Firstly, the surgical aspect of the procedure. An evac of the uterus can proceed to a hysterectomy. Where do you want to be when you do this evacuation of the uterus? If, for instance, you're doing it and there's an iatrogenic perforation of the uterus, are you going to be able to get to theatre? And these are the questions you should ask of any procedure. If it goes wrong, where do I want to be? How likely is it to go wrong? But because this talks about sedation, what we really want to ask is, how much stimulation or pain is there going to be, and how much sedation am I going to need? Now, sometimes you just need analgesia, sometimes you just need sedation or anxiolysis, but think about the specific procedure, because you're going to tailor your sedation to that procedure. Very painful procedures might actually not need sedation. They might just need local anesthetic and nothing else. Something like an evacuation of the uterus has indications for both. It's not, in terms of somatic pain, it's not very painful, but there is quite a deep visceral pain, and especially if you dilate, it's very uncomfortable for a woman. So she definitely will need analgesia. Does she need sedation? Well, it's not a very dignified procedure, and I think it probably is nice to have some anxiolysis. She's probably going through a grieving process, so anxiolysis and potentially sedation is probably warranted in most cases. Now, when you look at sedation, it's a continuum, and you need to think about which stage of sedation you're going to put this patient into. So there are 4 things that we would be interested in all these patients. How responsive are they going to be? Are they going to be able to maintain their airway? Are they going to breathe on their own? And what is the cardiovascular status, and how will it be affected by the sedation? And as you move from left to right in this table, you're going towards increasing depth, increasing complications, and you're needing more equipment and an increased skill set. So that's minimal sedation to moderate or conscious sedation to deep sedation to general anesthesia. And it's actually quite difficult to choose one area of this table and stay there. Often you'll drift between the 2 areas. And if you're going to do something outside of theatre or outside of an area where you can ventilate, you want to be on the left of this table. Minimal sedation, maybe into conscious sedation. And adverse events occur because people are not trained or inexperienced, or they've picked the wrong patients, or they're doing procedures that aren't suitable for sedation. People haven't appreciated that the drugs that they're using work together, or that there's an underlying pathology in that patient that makes them more sensitive. So these are the sorts of things you need to look out for, and which this guideline takes you through. So you need to at least decide, am I doing basic sedation or advanced sedation? Basic sedation has just a single agent. As soon as you use two agents that can cause respiratory depression, so for instance using midazolam and morphine, or using fentanyl and propofol, as soon as you're doing that, you're doing advanced sedation, and that has implications for where you can do it. Basic sedation, you can just monitor the patient clinically, they can speak to you, you can have someone just chatting to them. Advanced sedation, two agents, you must put monitors on them, and you must consider fasting the patient if you're going to take them into deep sedation. Basic sedation you can do on your own, so you can give them a little bit of sedation and you can do the procedure. If you're doing advanced sedation, so more than one agent, or even if you were using a propofol sedation, which would be considered advanced, you need someone doing the sedation and someone else doing the procedure. You can't do both. And that's because once you're doing the procedure, you're unlikely to pick up if the patient has a respiratory arrest or starts decompensating. And because of that fixation error on your procedure, you need someone else that is watching, even if it's a nurse who's not necessarily trained in sedation. At least that nurse will be able to watch the monitors and watch the patient and alert you to a problem that may have occurred. And then basic sedation can happen in the ward, but if you're doing deep sedation, you probably want to be in a theatre or in a procedure room at least, where you've got facilities to manage an airway if you need to. Some other principles, and these are fairly simple. Remember that titration eliminates the guesswork. So rather go in with your dosing of your sedation, use small doses and give them repeatedly. That means you can see how the patient's responding. So give a small dose of midazolam, see how they respond, give another dose, rather than give the maximum dose first up. So if you're patient with your sedation, you can eliminate that overshoot when you use too big a dose. Remember that sedation is not analgesia, so if the patient's in pain, it's not appropriate to give them midazolam or diazepam. You should give them something for analgesia, maybe in combination or maybe on its own. Patients that become restless, they need attention. It might be that you've given them a benzodiazepine and now they're disinhibited, but it might also mean that they're hypoxic or hypotensive. So when the patient starts to move, find out why. You mustn't avoid these things. Sometimes people are just, they lean towards giving more sedation to keep that patient still, and that can be a very wrong response. Remember, if you're somebody that uses a benzodiazepine and then gives the antidote, something like flumazenol, which is also called a Nexate, or you use an opioid and then you give naloxone, using the drug and then using its reversal agent can be problematic, especially if the drug that you're reversing has a longer half-life than the reversal. So if you give diazepam and then you give flumazenol, the patient will wake up and look great, and in a few hours time that patient will go back to sleep because the diazepam is now kicking in again and the flumazenol is worn off. So think about things like that. And finally, have some idea in your mind. When I say discharge criteria, usually we're not sending these patients home, but what I mean is discharge from monitored care, where you think this patient is now safe on their own. And sometimes if you've used an anesthetic like a benzodiazepine and some ketamine, that patient might have several hours before they're safe on their own. And the test that I'm always interested in is if the blanket or a pillow were to fall across the patient's face, would the patient move that off their face? And if you think they wouldn't, they really need to be in a monitored setting. Where should it be done? Ideally, what you do is if you're doing procedures in your ward, you set up a procedure room. Find a space where you can put some of your equipment. Remember that you're hoping for the best, but you should prepare for the worst. So this is a nice place to be, in a theatre when things go wrong, but I accept that you can't always take patients to theatre. Remember that when you're in the ward and the beds are all next to each other, if you have to get to that airway, that could be difficult. If they're cot sides up of a bed, can you get to the airway? And you've got to think through those things before you start. So I like, if I'm doing a procedure in the ward, I like to create space around the bed at least so that we'll be able to move. I like to know where the oxygen is, where the suction is, where my airway trolley is. Those things must all be available to me before I'll do something in the ward, especially where I'm running the risk of respiratory arrest or apnea. So if you're going to do it in the ward or the procedure room in the ward, sedation only, and you should not be using two agents or doing difficult procedures that can go wrong. If you're a beginner, rather practice these things in the theatre, or practice or you do your first cases in the ward, but have someone there who has some experience. Go there with a friend. And remember, these guidelines are there. You can always read through them. If you do these sedations, going and then reading around them will really add that depth of knowledge. Try what you can to use blocks. So the best way to do a procedure is if you can take away all the stimulation, then the sedation you require is really nothing if you can talk to the patient, or very minimal, just a small amount of anxiolysis. So think about using blocks. If you're doing a short procedure, lignocaine is probably a safer drug to use than bupivacaine because of the risk of intravascular injection. If lignocaine gets into the vessel, it's unlikely to cause a problem, whereas bupivacaine can cause major problems. Remember, if you're doing blocks, you can do them with or without adrenaline, but adrenaline should never be used where there's in capillary beds. Things like penile blocks and digital blocks shouldn't have adrenaline in them. Try and learn how to use the ultrasound. It's always makes these blocks better over time, and you develop your ultrasound skills. So just for some examples, remember that safety remains paramount. So blocks, they do have complications, and you should have the ability to manage those complications available. Brachial blocks, this is a brachial block being shown here. I find this one a particularly nice one because there's it's a shallow block. There's a vessel there to get your anatomy. This is a supraclavicular ultrasound guided brachial block. That might be too much for those people that have never done blocks, but if you are wanting to learn, this is not a bad one to learn. Wrist blocks are very nice, median and ulnar in particular. The radial nerve is a bit harder to block because it sends off proximal branches, but these two nerves are very easy to block at the wrist. It's with minimal reading, and I'll show you now where to go do that reading. Ring block. Ring blocks are very, very useful for digital trauma. Just remember that there is actually a right and a wrong way to do these. We probably teach that injection site as being too distal. So when you inject actually on the body of the finger, on that proximal phalanx, if you inject local anesthetic there and you create pressure in that compartment, you can damage the digital nerves, and they can actually end up with numbness on the side of the finger that is persistent. So you should do them more proximally where there is space for that local to spread. So right in the web, or even in the palm of the hand, if you're doing these things properly. Penile block, a very useful block if you're going to do an adult circumcision. Again, remember, no adrenaline. And there's a number of techniques. I tend to use a ring block technique. There are two techniques described, but the ring block technique has almost got 100% success and is a very useful block. Femoral block, also a nice, shallow, easy block to do. You can do it blind, but the best way to do it is with an ultrasound. Also a good one to learn. Saddle blocks are worth remembering because they have almost no hemodynamic effects if you give the right dose. So you give something like 0.5 mils of hyperbaric bupivacaine, and you sit the patient for 15 to 20 minutes, and then you'll have a very nice area of anesthesia for something like a perianal abscess. Should you do ankle blocks? I often get asked this question. I find them difficult blocks to do. There are 5 nerves that you need to anesthetize. There's the deep perineal, superficial perineal, sural nerve, posterior tibial nerve, and the saphenous nerve. So what you end up doing is putting a local anesthetic almost all the way around the ankle. Having said that, if you're doing something on the foot, it's very nice to not have to deeply anesthetize the patient. This is not going to help you with an ankle fracture, but it is a block where the risk is fairly low, and if you've got an area that isn't covered, you can always add local anesthetic. So it is one that perhaps you want to try, but because there are 5 nerves, the chance of not getting a complete block are unfortunately there, and I end up almost putting a bleb of local anesthetic all the way around the ankle. Sciatic blocks I just mentioned because sometimes people want to do below knee amputations or more advanced procedures under nerve block. if you're going to do a below knee, you have to get a femoral and a working sciatic. So the two of them together will give you complete analgesia, anesthesia of that lower limb. If you're doing an above knee amputation, you have to add the lateral femoral cutaneous as well. And these are difficult blocks. They're advanced blocks. They are doable. Certainly we do them in very sick patients sometimes. But I think that's a block for down the line once you are comfortable doing other blocks. And then don't forget a field block. This literally just implies that you surround the area with local anesthetic. And whenever you can in sedation, add local anesthetic. Because when you reduce the amount of stimulation the patient's getting, then the amount of sedation you have to give is less. So in terms of going to find places to learn how to do these blocks, I like Nysora. There's a website there that I've put on the screen. Like for instance, if you're doing the wrist nerve block, you can choose between doing an ultrasound guided, or they'll give you the landmarks and the nerve stimulated technique. So there's lots of ways that they'll show you. They've got really nice videos. They explain it really nicely. And then if you're that way inclined, you can get this app called the Nysora Blocks, which is available on iPhones and Androids. And they'll run you through videos and the anatomy, and very, very nice resource to use. So in terms of some broad recipes, always start with saying, can I use local anesthesia in order to take away that stimulation? So local anesthetic, and then usually if you're needing analgesia, pick one of the opioids. Fentanyl is probably the one that is the most effective. So 1 mic per kilogram, it's going to last 20 to 30 minutes. Pethidine, a milligram per kilogram, will work quite quickly, 2 or 3 minutes. It'll work within that time frame, and it will last 2.5 to 3 hours. They do get quite euphoric on it, so there is sort of more of a high with pethidine. And then morphine, 0.1 milligrams per kilogram, probably the least potent of those three, and lasts the longest, 4 to 6 hours, lower ceiling than the other three. But those are sort of the options that you can consider. And then add to that sedation. Midazolam is the one I've been referring to just because I know it's available. 0.1 milligram per kilogram often is a higher dose than I will actually give. So what I do is I look at the patient, and if they're 50 kilograms, I'll say, all right, that's 5 milligrams. And then I'll start giving a little bit of midazolam and just seeing how they respond. And often I'm giving 2.5, 3 milligrams of midazolam. Now the best way to do sedation would be to do propofol, like a propofol infusion of 1 to 2 milligrams per kilogram per hour, titrated to effect. I love propofol sedation. It's what I primarily choose, but this is not for beginners. Once you start using propofol sedation, you need to think about capnography or some way of measuring whether the patient is breathing. You need to be confident stepping in. There's a very high likelihood with propofol plus an opioid that the patient will stop breathing. So I'm putting it there because it's going to be in every single guideline you find, but be very, very careful. So if you're wanting to learn about propofol sedation, start in theatre. Start with your airway trolley out, with capnography, with an anesthetic machine, and ideally someone who is comfortable doing those sorts of procedures to talk you through them. Lovely way to do sedation, because when you switch it off, they wake up. A few minutes later, it's like they never had anything. It's good sleep, but it's something to only consider when you're at an advanced level. And then ketamine, and there's an argument to be made to say, why don't we just use ketamine, because it gives us analgesia and it gives us sedation, and it's fairly safe. So I've got a slide for ketamine. I'll come to it just now. The option that people will talk to you about is ketofol, which is a combination of ketamine and propofol, which probably enables the use of lower dose of both drugs. The official SASA recommendation is 10 milligrams of propofol to 1 milligram of ketamine, although you'll find in practice many people are using all sorts of different combinations, 1-to-1 even, which gives you much more ketamine, much less propofol. And probably in terms of respiratory arrest, the more ketamine to the less propofol is less likely to cause that problem. So ketamine, this is how I do ketamine. I always give a little bit of midazolam first. So the dose being 0.1 milligrams per kilogram, but that's probably too much when you're using it in combination. So I use a dose of something like 2.5 to 5 milligrams IV as a total dose. I give that first once the monitors are on, and that'll smooth out the anesthetic or the sedation. It'll take away those that hallucinations that you get, and that a lot of the movement you get as well. I then add glycopyrrolate as an anti-sialagogue, 0.2 to 0.4 milligrams. The dose is actually 3 to 10 mics per kilogram, so you can work that out if you like. And then once those two are in, I've now got a slightly sedated patient whose secretions are hopefully dried up. I'm going to use ketamine on top of that, and I titrate it. There's a number of ways to do that. You can use boluses of 0.5 milligram per kilogram IV, so I work out what that is, and then I give about that amount. The first bolus is going to be too little, but I like to see the response the patient's going to get, and then I'll just keep bolusing as much as I need, as often as I need. Another way to do it is to give IM ketamine, 5 milligrams per kilogram. The dose range is actually 5 to 10 milligrams per kilogram. I sometimes do this in pediatric patients because it works quite slowly, it's longer acting, and you can use it then to establish a line if you've got one of those kids where it's difficult to get a line. And then infusions, you can run syringe drivers, 2 to 4 milligrams per kilogram per hour. And there are lots of ways to do that. If you make the solution 4 milligrams per mil, you just run it at their weight, and then you're getting that 4 milligrams per kilogram per hour. So there are lots of ways to do that. Probably the easiest way in a district hospital is just to use midazolam, glyco, and then boluses as you need them. I'm going to stop there. There are some scenarios or examples that I'll take you through in the live presentation, but for now, those are the sedation principles and scenarios, and I hope you find that helpful.